All right, so now we're going to be breaking down different classes of antidepressants. And we're going to start with the classic antidepressant class that is probably the one most providers who prescribe an antidepressant are going to try first. And these are our selective serotonin reuptake inhibitors, or SSRIs. And SSRIs, like I had mentioned before, are used as an initial or first line treatment for major depressive disorder. They tend to be really well tolerated. There are some side effects, which we'll talk about. And one thing that we always consider in these types of products is if you take an overdose, is it dangerous? And fortunately, SSRIs are fairly safe in overdose, which is great. And one way to remember the SSRIs is FFPECS, or the way I remember it is selective serotonin reuptake inhibitors, or SSRIs, are so sexy. I know. Because they have full and fabulous pecs, FFPECS. One thing to know with that is you don't actually have to have full pecs for them to be fabulous. Fluvoxamine is actually not FDA approved for depression. We do sometimes still use it. And in a lot of the guidelines, it's included in the appropriate to start group, right? So these work by inhibiting the reuptake of serotonin. So again, name tells you the mechanism. So we have these little vacuums in the neuron, or the presynaptic neuron, that suck serotonin back into the neuron itself. So it's no longer in that space to activate serotonin receptors. So this allows for more serotonin to be available in that synaptic space. So we have fluvoxamine, or Luvox, fluoxetine, most commonly referred to as Prozac, but there are a couple formulations including Serafam, paroxetine, which is most commonly recalled as Paxil, S-citalopram, which is Lexapro, citalopram, which is Celexa, and sertraline, or Zoloft. So how these drugs work, as I had mentioned before, this picture right here. So we have, so right here, we're blocking that little vacuum that pulls serotonin back into the neuron. So that means we got more serotonin out here, which allows for more activation of our 5-HT receptors. So when we're thinking about these medications, we do want to think about the side effects and management. And one of the most common side effects that people will find problematic, rightfully so, is sexual dysfunction. So up to 50% of patients may have some level of sexual dysfunction from the use of SSRIs. And this can be a variety of different presentations, including difficulty achieving orgasm, difficulty experiencing an erection, or a delay in ejaculation, changes in libido. For some people, it doesn't matter. Maybe they're ace, maybe they're not in a relationship, sex isn't a huge deal. But for some people, this can be really problematic. So there are a number of ways that we can address it. Sometimes it's a motivation, that's the same thing when we talked about the boxed warning, although not as worrisome in a lot of ways, and that some symptoms get better before others. And sometimes just waiting, it gets better. We can add Viagra, which can help if someone in particular has, say, erectile dysfunction. You can add Wellbutrin or bupropion. And for individuals, particularly those assigned female at birth, that can actually relieve some of the sexual side effects. And switching antidepressants can sometimes work. It's about that individual's risk versus benefit. Other adverse effects of note include nausea, GI stuff. We actually have serotonin receptors in our gastrointestinal tract. So diarrhea, nausea are fairly common with these medications because SSRIs don't know that they should just be working in the brain, right? So they will interact with serotonin at other sites within the body, including in your gastrointestinal system. We can see sleep changes, and that can include sleepiness or difficulty sleeping. The most common one that's going to make it more difficult for someone to sleep is fluoxetine or Prozac. And the most sedating is paroxetine. And paroxetine has some antihistaminic, anticholinergic effects, which can make people feel kind of sleepy. The rest are kind of in the middle. Some people don't feel any different. Some people feel more sleepy. Some people feel less sleepy. Everyone's brain's a little bit different. We can see some weight gain with these products, less so with fluoxetine, and usually not a super, super high amounts of weight gain, but there is some risk with these products. We also can see headache, often self-limiting. And I'd mentioned before, increase in agitation or anxiety as the body adjusts to it. So sometimes, even if we're treating for anxiety, people might feel a little bit more anxious when they first start it, which can be difficult because that delayed response, that delayed benefit of the treatment. There's a small but sometimes significant risk of bleeding. So we have serotonin receptors on our platelets, which is part of the stuff in our blood that makes our blood clot. So it very slightly affects the body's ability to form a clot. However, in most cases, that's not clinically significant, unless say someone has a number of other medicines that also increase risk of bleeding, and they, or they have hemophilia or something like that. And typically, we're going to just educate to monitor for signs and symptoms of bleeding. The next group of drugs, which are also part of the workhorse, we use them pretty soon after a diagnosis, are the SNRIs, which are serotonin norepinephrine reuptake inhibitors. So as you probably guessed, they work on the serotonin receptor, but also, I don't know why my drawings are goofy, but also the norepinephrine receptor. So it's increasing the availability of two neurotransmitters versus just the one neurotransmitter that we see with our SSRIs. So the mechanism is listed here, and it is actually similar to those older drugs, the tricyclic antidepressants, but it's much more specific to just serotonin and norepinephrine versus our tricyclics, which we'll talk a little bit about later. They actually can be used initially for major depressive disorder. A lot of times people will use it second, but if someone has a really good reason to be on an SNRI, say they have fibromyalgia, or they have diabetic neuropathy, or they have some other good reason to be on an SNRI, they can get benefit in more than one condition by starting SNRI, totally appropriate. So this would be totally fine as an initial treatment. Now, if you were to take a test and I was to write a test question, I wouldn't have anyone discern between using SSRI or SNRI first in this scenario. If someone had diabetic neuropathy, might be smarter to use this type of product first, or really Cymbalta with chronic pain as well. So things to think about. From an adverse effects perspective, very similar to our SSRIs, except we do see some of that norepinephrine start to come in. And we have to think about how norepinephrine affects our bodies as well. So that means that there's an increased risk of blood pressure increase. There is more propensity for insomnia versus sedation, but we can still see that sometimes. Tremor, right? Feeling a little bit more activated. Our products are listed here as well. So we have duloxetine or Cymbalta, venlafaxine or Effexor, desvenlafaxine or Pristiq, and levomilnacipran or Fetzima. Duloxetine also has more drying effects and can cause urinary retention, so difficulty peeing, and a bit more risk of liver issues, so hepatotoxicity. Moving into our next class, so we're going through all the big classes for this video, is our NDRI or norepinephrine dopamine reuptake inhibitor, commonly known as Wellbutrin or bupropion. So this is what it sounds like. It increases the availability of dopamine in norepinephrine. So this is a non-serotonergic antidepressant. So some people, if they're really sensitive to serotonin, then this might be a really good option for them. It does tend to be more weight neutral to actually weight loss, which can be good or bad depending on the individual. It still can cause that activation because of the increase in norepinephrine. We can see increase in blood pressure. We see some dry mouth. Has very low risk of sexual dysfunction, which is great. Things to take into consideration, though, we really don't want to use it in these individuals. Okay, so individuals who have seizure disorders, because bupropion is known to what we call lower the seizure threshold. So everyone has a threshold for when a seizure would happen in their brain, and it's different from person to person. Most people, it's pretty high unless you have a seizure disorder. But if you take significant doses of bupropion, that increases your risk of seizures. It actually makes your brain more sensitive to seizures. Alcohol use disorder, mostly due to actually abstinence from alcohol. So some that affects the seizure threshold as well. So if someone chronically uses alcohol and then they stop suddenly, one of the risks of alcohol withdrawal is seizure. And Wellbutrin or bupropion can increase that risk of having an alcohol withdrawal related seizure. Bulimia and anorexia nervosa, we tend to avoid using this product as well due to some of the risks with actually seizure risk with those electrolyte issues, nutritional issues that we can see with eating disorders, but also because of its appetite suppressing and weight loss effects that individuals can experience can be counterproductive for individuals who have anorexia nervosa or bulimia. So being thoughtful about those. Related to Wellbutrin is this newer product called Auvelity or bupropion plus dextromethorphan. So both of these are products that have existed for a while. Dextromethorphan is cough syrup, or Delsym is one of the common brand names. But it is an uncompetitive NMDA antagonist. So it actually affects the NMDA receptors. And these are associated with glutamate. Glutamate can actually improve mood, right? Tends to be a bit shorter term, but works faster. So we're actually taking bupropion, and what bupropion does here, it actually boosts the dextromethorphan. So there's a drug interaction happening, but it's a drug interaction that we're doing on purpose. So if you just take Delsym, it doesn't hang out in the brain long enough. It doesn't do what it needs to do long enough to be an effective antidepressant. But if you give bupropion at the same time, it increases the amount of time that the dextromethorphan will hang out in the brain and do what it needs to do. Similar cautions with bupropion. We also can see some risks with high exposure to dextromethorphan that we do have to be a little bit cautious about, but it does work a little bit faster in some of the primary studies that got the product approved. So you can kind of see this is bupropion at a fairly standard dose. We do see that improvement, which we would expect on this top row here. So this improvement here you can see with bupropion, which is great, but you add the dextromethorphan and you'll see it actually separates, if I remember, maybe not at the first week, but pretty quickly it'll separate statistically from one another. So usually we see that significant improvement within 4 to 6 weeks with a traditional antidepressant. We add that dextromethorphan to this with a drug interaction from bupropion, and it works a little bit faster, which is neat. So mechanistically, this is just what you see, those inhibition of the reuptake of norepinephrine as well as dopamine, which allows for more availability. And then with the dextromethorphan, that NMDA receptor antagonism that can help with regulation of glutamate. Okay, moving into our serotonin antagonist and reuptake inhibitor, also referred to as a SARI. This is one that we actually use more commonly to promote sleep, despite it not being FDA approved and not highly recommended in the insomnia guidelines. But I clinically see this used for sleep all the time. It's not super commonly used at antidepressant doses to treat depression. Part of the reason for that is high doses that are needed for depression, so 150, 200, 300 milligrams, are so sedating. They just knock people on their butts. It's hard to tolerate. We also see some what we call orthostatic hypotension, which means that when people stand up, their blood pressure kind of bloop, drops down. And that can be challenging. People should get up slowly, move a little bit more slowly, especially when they first start it. And rarely, we also see this condition called priapism. We can see priapism with other types of drugs, but the most common one that can cause priapism is trazodone. And priapism is actually a prolonged painful erection. Kind of like if you've seen commercials for Cialis or Vag or whatever when it talks about that. And that can be dangerous. That can actually cause loss of function and is a medical emergency. So it's a big education point if you're a pharmacist, making sure that patients are aware when they start trazodone that risk is there, and it's not something to be like, yay, my function is improved. It can actually be quite dangerous. Related to trazodone or Desirel is vilazodone or Vibrid. This actually works kind of similarly in that it has that reuptake inhibition, but it actually has partial agonistic activity. So if you guys remember partial agonist activity. So this one, we see 5-HT2. It is an antagonist. This one, 5-HT1A, it's a partial agonist. So it kind of modulates the activity of those receptors. And we have lots of serotonin receptors. Some are much more associated with depression and some aren't. So by kind of modulating some of those interactions, the hope is to have more antidepressant activity. So you're getting more bang out of your serotonin buck, if you will. Biggest side effects are the common ones. So stomach upset, diarrhea, dry mouth, dizziness, sleep changes. So this is what we see, right? So we have our 1A receptor, our 5-HT2. We see our reuptake. Don't worry too much about this one. Nifazodone is one that is still available, but very, very hard to come by, has some risks connected to it. So we're kind of starting to be more specific about which serotonin receptors and almost kind of funnel that serotonin so that it activates more on the receptors we want it to. Speaking about funneling and picking and choosing, we also have our NASA, or noradrenergic and specific serotonergic antidepressant. And this is mirtazapine or Remeron. It's a really neat drug, hard to explain the mechanism of action. But essentially, what it does is it blocks receptors prior to, so the presynaptic receptors that will promote release of neurotransmitter. So by antagonizing these alpha-2 adrenergic receptors, which respond to norepinephrine, it'll enhance essentially the release. And then in addition to that, it will affect the postsynaptic 5-HT receptors. So it actually blocks 5-HT2, 5-HT3, so that there's more serotonin for 5-HT1. So we see less stomach upset. We see slight changes in the side effect profile. Biggest things, sleepiness. Makes people sleepy. Makes people real sleepy. Makes them hungry too. So we can see weight gain, sleepiness, constipation, etc. This is kind of what it looks like. So as you can see, it's affecting up here, right, which will enhance release of your serotonin and norepinephrine, and then this funneling effect down here. Okay, so noradrenergic and specific serotonergic antagonists. Finally, in these these newer-ish primary choice drugs, so these are all kind of appropriate to use pretty early on, is vortioxetine or Trintellix. So this is another SSRI with benefits. So this is an SSRI, but it also agonizes or activates 5-HT1A and has this kind of mixed partial agonism, antagonism. So again, we're increasing the availability of serotonin and funneling it down. Biggest side effects we see with this are stomach related. So nausea, constipation, and vomiting. Next up, we're going to talk about some older drugs and some of their challenges with utilization, and then spend some time talking about some of our more miscellaneous, rarely encountered products.